Recording in progress.
Very good. Perfect. So I just want to welcome everybody to today's presentation. It is entitled Pulmonary Function Testing, Making Sense of Your Numbers. And our guest speaker today is Dr. Jaspreet Kambo, or Jas. So I'll do a bit of an introduction and then pass it off to him. A reminder to everyone that any questions that may come up during the presentation, please put in the chat box. We will address them at the end of the presentation. We only have Dr. Kambo until about 2:45, so we want to make the most of the time. And I think that's it. Just a reminder that the presentation for next month will be September 21st, and it is Action Planning, Getting to Know Your Baseline. And our presenter is Tracy Gallant for that one. So a quick little spiel about Dr. Kambo. He has been practicing since completing his respirology residency in 2008. Since matching into the respiratory program in Saskatchewan and completing additional training at Queen's University, Dr. Kambo took an appointment in the interior of British Columbia, where he has worked in both the public and private sectors. In addition to providing call services for the hospital in town, completing diagnostic interpretations, and seeing a variety of respiratory patients in his private practice. He's a little bit busy. Dr. Kambo sits on the advisory committee on diagnostic facilities, the ECDF, it's a long one, to ensure diagnostic facilities within the province are providing the best practice. During his off time, which isn't very much, Dr. Kambo is a very proud father of 3 young children, and he has been lucky enough to marry his best friend and partner in crime, and he remains active as much as he can in all sports. So I will pass it over to Dr. Kambo. Thank you so much for attending, and take it away.
Thank you, Lindsay. You hear me okay? Okay, and the screens, like the presentation has come up? No?
No, not yet. I can see you.
So share your screen again, Jess.
Aha. How's that?
Perfect.
Yes.
And we see our view. Lovely.
Good. Let me get this up here. Perfect. Okay, so I've been asked to give a little overview of making sense of the numbers that we look at when we're trying to decide whether or not somebody has COPD. My hope is that you walk away from this thinking, why the hell do these people spend 2 years studying this? It seems so simple, but if it gets a bit technical at spots or at times, hopefully we can clarify that with the questions at the end. Overall, we'll talk about what a pulmonary function test is, what types of tests there are, why we do them. We'll give a couple of examples towards the end, and hopefully you'll be able to relate that to the numbers that our lovely respiratory therapists, such as Lindsay and Alexa, provide for you when they do your testing. So what is a pulmonary function test? It is non-invasive, meaning there's no cameras going anywhere, there's no needles going anywhere. It's a non-invasive test that gives us a lot of information about your lungs. It tells us how much volume your lungs can take in, the size of your lungs. It tells us how well your lungs can move air in and out, which is one of the most important functions of our lungs. It also tells us what our lungs' ability is to take oxygen from that air and bring it into the body. The talk today is going to focus on COPD. So some of the tests that are encompassed here aren't going to be relevant for today's talk. We'll touch on them a little bit. But overall, we're going to try to keep this on a COPD focus and talk about the key measures for COPD. When we talk about pulmonary function tests, that opens up an entire slew of different test types that we can do, and not one pulmonary function test is not the same as the other, For COPD, by far the most important one is the spirometry. So a bulk of the slides today are going to address the spirometry part of it. Lung volumes are also important. They provide a lot of important information, or secondary but important information for COPD. But if I'm seeing one of my COPD patients and they don't have full lung volumes, it's not the end of the world, but it is helpful. Gas exchange is the other big one as well, or the other big secondary measure we like to look at as well when we're trying to build a case for COPD or get an idea as to the severity of the COPD. We'll go into these into a little bit more detail as we move on. The next three tests, the Inspiratory, Expiratory, 6-minute walk, Methylcholine challenge test, you may have had some of these. Generally, we don't need a ton of the information from these as it pertains to COPD. The 6-minute walk test, some of you may have had in the context of seeing whether or not you qualify for supplemental oxygen. If any of you are into the transplant world, you'll be very familiar with this test as well, which gives our transplant physicians a gauge as to how you're functioning and helps them to stratify how urgently you need to get a new set of lungs into somebody. But for the most part, when we're talking about COPD, spirometry is king, and lung volumes and diffusing capacity also important or helpful, but not critical. The reason I'll talk about spirometry a lot as well, some of you may have been told you have COPD without any kind of formal breathing test. You know, they've heard that you smoke, they assume you have COPD, or they saw a chest x-ray and assume you have COPD. I tend to be pretty easygoing, but I am a huge stickler for getting the appropriate test for the appropriate diagnosis. So if anybody ever tries to tell you you have COPD and hasn't done a lung test or a spirometry at the very least, you can tell them that Dr. Kambo says no. So why do we do pulmonary function tests? We've already kind of touched upon this in the context of COPD. If some of you went into your doctor's office and know someone with COPD, maybe you walked in saying, hey, I think I have COPD. But for the most part, what we're investigating are symptoms. Doc, I've been short of breath for the last little while. I can't do the things I used to do. I'm coughing, I'm wheezing. This is the spirometry and the pulmonary function tests are the heart and soul of testing for my specialty here. For some diseases, not necessarily COPD, we use it to not only to monitor as well, to assess the efficacy of treatment, and from a very, very practical perspective or practical issue, if we're trying to get the government to pay for some of our medications, like our inhalers, we need these numbers in order to get that approval. Overall, though, the role of spirometry in COPD is largely to establish a diagnosis. I don't often use it to track progress because we know the nature of COPD already and how it tends to progress. Rarely will I do repeat a spirometry for that perspective. The biggest thing is to help establish the diagnosis in COPD. If you have asthma as well, then we get serial testing, but that's a whole nother kettle of fish. So when we do these tests, there are huge, excessively huge databases on what's considered normal. So when you are diagnosed with something like COPD, it is based on how your values look compared to the rest of the population or the rest of your population, controlling for age, gender, height, and ethnicity is starting to come into it as well. So if you're a 65-year-old Caucasian female, your values are not being compared to a 28-year-old South Indian male. You know, it's apples to oranges. Whenever we do these values, we see what your numbers are, we compare them to what the normal is, and that helps to establish whether or not you have a disorder like COPD. Spirometry. So we talked about this being the heart of testing. Most of you, I imagine, if not all, have had spirometry where you're given your nose clips, a mouthpiece is put in, you're asked to take a big breath into the top of your lungs and blow out as hard and as fast as you can. And then you're given a puffer, and that process is repeated. That is the test that's used, that's the spirometry that's used to establish a diagnosis of COPD. We can also look for evidence of asthma in there as well. You see here in the red that if there's a significant improvement in your numbers with the inhaler, that tends to suggest asthma, whereas if there's no improvement, that tends to suggest COPD. In no way is that a hard and fast rule. No way whatsoever. We have asthmatics who we don't get that reversibility. We have COPDers for whom we do get that reversibility. That reversibility, if you see it on your test, whether or not it's a relevant measure for you as a COPD patient, is largely going to depend on whether you have a coexisting diagnosis of asthma, and establishing that diagnosis of asthma is going to depend on your history, your physical exam, and the assessment made by your family physician or nurse practitioner or RT or whoever. Right. In the within the spirometry, there are two key values that we get. So if you recall, you're asked to take a big breath in to the top of your lungs and blow out as much of that air as you can until you're feeling blue in the face and you're being told to blow, 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 blow. What that tells us is how much air you are capable of blowing out. I'm going to talk a little bit about what COPD does to your lungs. Nobody in this world can blow out all of the air in the lungs. You could be an Olympic level air blower and still try to blow out every last ounce of air that's in your lungs. Cannot do it. So what this measure tells us is, functionally, if I were to ask you to empty out your lungs, how much air can you get out? And of course, whatever number that turns out to be, as we mentioned, we compare it to age, gender, height, ethnicity norms, and determine whether it's a normal or an abnormal value. So from this slide, one of the measures we look at is how much air can you blow out? If your number is low, there's no such thing as too high. Too high just means you're really good at it, but there's no disease process we worry about with a low number here. If your number is low, if the amount of air that you're able to breathe out is lower than what we would expect for a person of your demographics, that either means, or generally means, one of two things. It means your lungs are just small, possibly from another lung disease, or it means that of all the air you have in your lungs, you simply cannot get it out. It's getting trapped in there. So the way I always tell my patients in office, where I can demonstrate my grade 1 drawing skills, the way to think of your lungs is to think of a tree. You look outside your window, you see a maple tree, and it has a trunk. And then that trunk divides to right and left. And then it keeps dividing and dividing and dividing. And every subsequent branch gets narrower and narrower and narrower. And at the end of these branches, you've got the leaves. And these leaves capture sunlight, turn it into oxygen, and that's why the rainforests are called the lungs of the earth. That tree trunk and those branches have absolutely no role in creating oxygen. All they do is hold up the leaves high enough so that they can capture that sunlight and turn it into oxygen. If you take that tree, turn it upside down, shrink it 1,000 times, and put it in your chest, that's basically what your lungs look like. So instead of a trunk, you've got your windpipe, or your trachea. And instead of those branches, you've got further airways that get smaller, and they divide as they go out, and they get smaller and smaller and smaller. And at the end of those airways, you've got these things called alveoli, or basically the leaves of the lung. So when you take a breath in through your nose or your mouth, that air travels through the big airways and is sent all the way down to the alveoli. The alveoli takes the oxygen out of that air, brings it into the body. And then with that residual air, you blow it out. I hope I haven't lost too many of you at this point, but we can clarify this towards the end. So basically, you take a breath in, the alveoli take the oxygen, you breathe out. When you have COPD, bringing air in, not too much of a problem. The big issue becomes when you go to breathe that air out. So normally, in a person such as myself who doesn't have COPD, if this is the caliber of my airways, like a tunnel, when I go to breathe out, it shrinks a little bit, but there's still enough patency there for that air to get out. When you have COPD, the integrity of those larger airways, the windpipe and the 2 or 3 generations beyond that, when you breathe out, instead of going like this airway goes more like this. So it becomes exceedingly difficult to get that air out of your lungs. When you do your breathing test and they ask you to blow out hard and fast, not only do they measure the total amount of air coming out, they're measuring the amount of air that's coming out in the first second. And if that number is reduced, that represents disease of these larger airways, such as COPD. So the FEV1, which is the amount of air that you can blow out in that first second, is a key measure to how severe your COPD is. And that gets expressed as a ratio, which we'll talk about in a second. But the takeaway from all of this babbling about trees and maple trees and whatever and whatnot is that when you're doing your spirometry and you're blowing out hard and fast, they're measuring how much air comes out in total and how much air comes out in that first second. And those are the numbers that we use to establish a diagnosis of COPD, because the amount of air, not only that you're able to get out, but in that first second will be affected by COPD. And similarly to your FVC and your FEV1, we have the same values of age-related, gender, height-related norms. The garden hose and the straws are basically an analogy for the large airways and the small airways. So we take this number. Most generally, people with COPD can still get the majority of their air out, except when we're in the extreme cases. But the majority of our COPDers can still get all of that air out, but it comes out way, way slower. If you recall, your airways, when you're breathing out, go from this to this. So you're trying to push a bunch of air through this small opening. It'll still get through, it just takes a long time. So what we do is we take that FEV1, which is the amount of air in the first second, and we make a ratio with the total amount of air. And if it's less than 70%, and there's some debate amongst the academics as to what the number is, but that's a debate for all the conferences. But for our intents and purposes, if the total amount of air that comes out in the first second is less than 70% of the total amount of air, then we've established a diagnosis such as COPD. So when you're doing those breaths out, if the large airways are compromised, the FEV1 will be low compared to the FVC. Or in other words, the amount of air out in the first second is less than what it should be relative to the total air out. And that is how we establish the diagnosis. And that's why those tests are important. When you get your printout, or when you get your sheet, you'll see some other values on there. This FEF 25 to 75 is more a reflection of the smaller airways. So remember what the big ones, you got your windpipe, you got your big airways that divide and divide and divide. And as we divide, they get narrower and narrower and narrower. This FEF 25 to 75 gives us an indication of whether or not there's any disease in the smaller airways. It's interesting to know, but in all honesty, between you, me, and whoever's listening in on Facebook, this measure is not very well validated, doesn't guide any treatment. It may be an indication that you're on your way to getting COPD if you don't have it already, but it's not something, I wouldn't lose too much sleep about this number. The FEV1 and the FVC are your main targets when we're trying to focus on this. Similarly, if you don't do the test properly, you're going to get, this applies across all of these measures. If you're not doing the test properly, we're not going to get good results. So if somebody like Alexa or Lindsay asks you to take a big breath all the way out and all you do is this, well, we're not going to get proper results. You're going to get false numbers, and it's of no value to yourself. You'll also see a number on there that says peak flow. That just pretty much tells you the flow rate, how quickly that air gets out. So the FEV1 tells you the volume of air you're able to get out in 1 second. That gets kind of re-expressed as this peak flow. I don't use it in my COPD ears, not a lot of value in my practice here. If you have coexisting asthma, then there's value to this. So when we do an asthma talk, we'll focus a little bit more on this. That. Diffusing capacity is a measure of how well our lungs can take the oxygen from the air that they're receiving and bring it into the body. Very, very helpful in helping us determine whether somebody has asthma, COPD, or something else. There are a lot of different diseases that can cause abnormal diffusion capacity. So if you get a report back and your diffusion capacity is low, it's not an instant, oh, well, I have COPD. I mean, it could be, but there is a huge list of things that can cause that. This is not diagnostic of COPD, it's more collateral evidence or supporting a case of COPD when we're still kind of wrestling with whether or not we've established a good diagnosis. But as you can see from the list there, which you can read as well as I can, there's a few different disorders that can cause low diffusion, COPD, and emphysema being one of them. If you're one of my patients, you may have heard me speak about got mild COPD, moderate COPD, severe, very severe. That's based on a few different things, but mainly I look at the numbers. Numbers are not subjective. Numbers don't lie. Numbers are, provided it's a good quality test, a number is a number, it's objective, it's easy to measure. So depending on what your FEV1 is, or how much air you're able to blow out in that first second of exhalation determines how severe your COPD is. Symptoms don't always correlate to severity. So I've got people who have an FEV1 of 35% still out there and fairly minimally impacted. I've got people out there with an FEV1 of 60% who can, have a lot of trouble just getting down the block. So there is a lot of variability in terms of symptoms and how they correspond to these numbers. Overall, though, when we're talking about severity, when I'm communicating, to your primary care physician or to the transplant team, and they want to know how severe the COPD is, this is where it gets based on, largely. So that's the bulk of the COPD spirometry stuff. There are other disorders in the lung as well, and we'll often do full breathing tests to look for those, as you can see here. So an obstructive disorder is like COPD. Anything that obstructs the flow of air out of your lungs is classified as an obstructive disorder. Any disorder that causes your lungs to shrink is a restrictive disorder. And both of these disorders are measured on spirometry and full PFTs. As you can see, there's a lot of overlap. There are some key differences there. So just looking at the spirometry by itself doesn't necessarily help us to determine between an obstructive and a restrictive disorder all the time. And we'll see that in our examples coming up. And so there are times where you may do that spirometry and your doc says, hey, we need to do further testing. Oftentimes it's because the spirometry itself doesn't help us to determine between them. Sometimes does, sometimes doesn't. For any of you who have received your printout or looked at your breathing tests in Kamloops anyway, you'll have gotten something that looks like this. So looking at this one on my left, screen left, where the mouse is floating over, let's focus on the first 3 lines here. First up, FEV1 to FVC ratio is 55. So the amount of air, the proportion of air that this person is able to blow out is less than 70% in the first second of the total air. And so that in and of itself establishes, yes, there is some airways disease there. Their FEV1, which is the total amount of air they're able to get out in that first second, is 88% of what we'd expect. So it's mild COPD. And the total amount of air they're able to get out is more than normal. So this is a pretty straightforward, some disease in the large airways. When I say large airways, 95% of the time, it's either COPD or asthma. Over on the right here, well, my right, stage right, there's a printout you'd get from when you go to one of our community clinics here. So again, looking at the FEV1 to FVC, the proportion of air out in the first seconds is less than 70%, so they get classified as having that airways disease. The total amount of air coming out in that first second is 62%. So moderate. The key difference between this test and that first one is now the total amount of air coming out is only 76% of predicted. So whereas over here, our patient is still able to get all the amount of it, or get the amount of air out that we expect them to, over here, they don't have the same amount of air. And that either means they have really severe COPD, such that when they're blowing out, their lungs aren't just narrowing, they're collapsing. So a bunch of air that wants to get out can't, because that airway or that tunnel that it goes through is completely shut off. So it either means they've got something called gas trapping because they're COPD, or it just means they have another lung disease where their lungs are smaller. Like that's all the air they have in them, which would then necessitate further testing to further clarify. Hopefully that isn't too technical, but we can try to clean that up for you at the end if we need. This is redundant, so we'll move past. Our pulmonary function loops, it's basically everything that we've spoken on today. It's just taking it and putting it in graph form. Won't spend too much time on this. The amount of this over here is what normal should look like, a nice smooth exhalation. When you have COPD, this arm tends to scoop. I mean, unless you really are sitting there studying your test, most people don't even notice this, but the shape of this curve helps us to make that determination as well. I think we've got 3 minutes left here, so we'll quickly try to get through this part of it. Some of you may have had a needle poked into your wrist to look for oxygen levels, to look for carbon dioxide. So when we do that wrist sample, it is the purest measure of how much of our key gases in our body are. pH tells us whether it's too much acid, too much base. It tells us the amount of carbon dioxide, which is a waste product. So in people who have COPD, our ability to breathe that out is compromised. So carbon dioxide tends to creep up. Oxygen, it tells us oxygenation, tells us our bicarbonate, which is a buffer. Don't need to get too much into that. And it tells us the amount of hemoglobin that is filled with oxygen. The key measures, I think, as for the purposes of our talk today here, are the pH, the carbon dioxide, and the oxygen. We've got our normals for oxygen as well, just like we have for everything else. There are some age-related adjustments that can be made, but largely normal is 80 and plus, 80 to 100. If you look at the symptoms of low oxygen, if you look at each of these symptoms here, about 20 different disorders could cause any of these. Just to hammer home the point of low oxygen in terms of symptoms comes with such non-specific findings that if you come into the emergency room, it's a reflex. We just check your oxygen right away, because no matter what symptoms you're giving us, it doesn't necessarily help us narrow it down. Like, no one's going to come with a constellation of symptoms and I'm going to say, oh yeah, you must have low oxygen. I mean, it's on the list, but there's no one specific symptom to tell us about low oxygen. Best way is, or if you're curious at home, a lot of my patients have gone and bought one of those little finger oximeters to measure that. I'll have people come in telling me my oxygen is way low, and I check it and it's 98%, but they still don't believe it. So, carbon dioxide, similarly, this is a waste product. This is stuff we want to breathe out of our body. When we have COPD, we can't breathe it out and it builds up in our system. Similarly, has a bunch of non-specific findings as well. So I think that's the bulk of, well, that is the bulk of what I was going to say. When you do your breathing test, it gives us an idea as to what your lungs are at that time. One of the good things about COPD, but one of the helpful things diagnostically is that it tends not to change over time. So if you have COPD in January of 2021, if I were to repeat your breathing tests in February of 2022, you should still have it. When you do it 4 years from now, you should still have it, which is why I don't necessarily track it. When you're doing your breathing tests, giving your respiratory therapist all the information they're asking for, which will help us to determine whether this is a true reflection of whether or not you have COPD, it'll help. If you come in with a rip-roaring pneumonia, well, of course, your numbers are going to be different than what they are at your best. So we'd like to see you at your best when we're establishing a diagnosis. And it may seem like they are cruel people when they ask you to blow it hard and fast, but the harder you work there on that test, the better the results are. So if you've been given an FEV1, hopefully now you know that, whatever that number is marks the severity of your COPD. And I think we open up to 10 minutes worth of questions if we have them.
Thanks, Jazz. That was great. I'm just going to stop your screen and open up the floor to any questions. There were no questions put in the chat box. So if you have a question for Dr. Kambo over the next couple of minutes, unmute yourself and ask away.
Okay, I have a question. It's a comment.
And
I was tested. I'm sorry?
Who is this?
Maureen.
Maureen, okay.
I was tested a few years ago with that spirometry thing. Sorry. I was never given a printout, so I had no idea about my numbers, but it was interesting seeing everything, and it just gives me a better understanding of what I have and how it's going and whatever. So I appreciate that very much. Thank you.
No, that's all right. Maureen, you're allowed to have that test as well. So hopefully if you just walk into your family doc's office, you can go in and grab it if it's of interest to you to have that.
Right. No, it was a few years ago I had it. I'm getting worse, I realize, which is what COPD does. So I don't think it'll help me with anything. I mean, I'm pretty cognizant, I think, of everything. So, but it was just interesting seeing what the numbers were and how my lung therapist or doctor looked at it and whatever, because anyway, it was just very interesting.
Great.
Thank you.
Thanks, Maureen. Anyone?
Yeah. Sorry, can I go ahead or is it somebody else?
Go for it, Carl, it's yours.
Some time ago, I bought this Aerobica thing that's supposed to remove phlegm from my lungs. At least it claims to do that. I've read the instructions many times. I tried different ways to make it work. It has never done what it's supposed to do. Is my condition beyond what it can help me for, or is my condition anywhere near what this thing can do?
So, I mean, first I'd have one of our friendly community RTs check that they've shown you how to use it properly. When we're dealing with thick, tenacious secretions, aerobica is one of the options, and I'll often tell people, you know, my experience, some people swear by it, other people get no value out of it. So if you're using it and you're not getting any value out of it, there's a couple of other options to try. If we exhaust all 3 or 4 of those options and you've done them properly and you just can't get that phlegm out, the sad reality then is that you're likely going to live with a lot of phlegm in your lungs. The important thing is that you are able to get it out. And if there's any kind of option, if this cough is impairing your quality of life, in spite of all the different things they can do to try to clear that out, it's worth a chat with either somebody like myself or one of your family care physician to see, look, I got all this phlegm. For example, I can't sleep at night. What can we do? And we can sort of come up with a creative way to at least make it such that it's not impairing your day-to-day function.
Thank you.
Yeah, and Carl, did you watch the previous webinar that we had last month, getting the goop out and ways that you can help yourself thin your secretions and get them out a little bit easier? Were you able to?
I don't remember, so I probably didn't watch it. Maybe wasn't aware of it or missed it, but I sure would like to not miss it.
Yeah, and it's on the website and they're recorded. So you can go ahead and watch that and see if maybe some information is of use to you as well. Yeah.
I can pop the link into our chat box. The other thing, Carl, do you take a bronchodilator daily?
I'm on, well, what's this called? Trelegy, and I was on Brio before that until my doctor changed it from Brio to Trelegy. Okay. And I've been doing it for the last 7 or 8 years. I find it very helpful. I have no problem breathing anymore, at least not to the point where I think it bothers me. So the answer is yes, I take these things every day.
Awesome. Sometimes it's if you have like a short acting, the physiotherapist that mentioned in our last presentation, you can take like your Ventolin or anything prior to help open up the airways prior to using the Aerobica. But yeah, just making sure that you're using those bronchodilators daily as prescribed to make sure the airways are open to be able to get the goop out.
Yeah, I think they're doing a good job and I'm happy they're available.
Oh, great. And Maureen just posted the presentation in the chat box so that you can go ahead and listen to that.
Good. All right. Any other questions? We've got about 5 more minutes with Dr. Kambo before he has to run away and see other patients. Marianne? Yeah, go ahead and unmute yourself. There you go.
Thank you. This is Marianne. That was so interesting, doctor. I have an appointment coming up on September 7th. Since October, I have a brain bleed, and I'm getting better because now I'm doing yoga and my exercises. One of the questions I want to ask the doctor, he calls my COPD severe. I want to say, what the hell? Am I dying or what? But I have not had a second test. Is the brain bleed getting in the way of my COPD is my question.
No, completely different. It's a completely different phenomenon. Should not be affecting the COPD. It affects the time frame. Like if you needed repeat testing, they wouldn't do it for a while because of that bleed. In terms of the dying question, I mean, I don't know you, but people can live with severe COPD for a very long time. Generally, COPD, sure, can take quantity away, but it often affects quality of life as much, if not more than quantity. So even if you've been classified as severe COPD, in general, that is not necessarily a quote unquote death sentence. You know, there are some diagnoses where I give patients and we know there's a finite amount of time that they're expected to live. COPD is not one of those. It's going to highly vary based on your past medical history and your personal circumstances.
Thanks, Marianne. Diane had her hand up, so if you'd like to ask your question.
Thank you very much. Yes, I was diagnosed with COPD emphysema. I also have lung cancer, adenocarcinoma, for which I received radiation this winter. It was upper left lung. Now, how does that mesh, or how does that hinder or help, or how does that work with emphysema?
Well, the radiation or the cancer?
Well, both. Will the radiation make things worse with emphysema?
It can, even independent of emphysema. There are, like if I were to give you Tylenol, there is a chance of a complication coming from that. When they radiate your lungs, there's chances of complications from that. Not necessarily just because you have emphysema, but because you're getting radiation to that spot, which can lead to inflammation and scarring. Having emphysema already, your lungs are already damaged to an extent. Their reserves aren't what they would be before the COPD. But when we're dealing with a cancer, we know if we do nothing about the cancer, it's going to eventually spread and take your life. And so when we do the radiation, it's like we kind of accept there's a chance that this is going to worsen my lung function, but it's in a sense the lesser of two evils.
Thank you. I understand. Right.
The emphysema itself, like even if I had somebody without emphysema, they would still get counseled about the problems that can occur with radiation.
Thank you.
Perfect. Any other questions? We've got about 2 minutes before he has to jet off. So now is the time if you have any questions. I'm getting some head shakes. No, no, no. Anyone? Okay, well then I want to say thank you so much to Dr. Kambo for taking your time out of your busy, I know, busy schedule to participate in this. I really appreciate it. So I'll let you jet away.
It was less work doing this than having you follow me every week. Asking me to
you guys, I fought for him. What I do. Harassment until they say yes, right?
Thanks,
Thank you very much. It was very interesting. Thank you.
Thank you.
Glad. Thank you.
And don't forget, all you guys, for next month, September 21st, register for the next presentation.
We have a guest speaker, Tracy Gallant, one of our community respiratory therapists. She's going to do wonderfully. So we'll see you then.
Thank you very much.
Thanks, everybody. Good seeing you.
Bye-bye.